Hi everyone, welcome back to my video series on preventive health for the USMLE Step 2 CK. In my previous video, I talked about the various risk factors and how to screen for CVD. In this one, we'll be talking about how to interpret those results and then talk about the appropriate way to manage such a patient. Now, with that, let's go to a question. Here we are. So you have a 47-year-old white male who's in your office for following up the results of his fasting lipid profile. He has no complaints, he's a non-smoker, drinks 2-3 beers on the weekend and exercises 20 minutes thrice a day. He has a past medical history of diabetes, well controlled on metformin. His father had an MI at 60 years of age. His vitals are normal, his physical exam is normal. Here are his labs. Then we use all this to calculate his 10-year risk of CVD using the AHA, also known as the pooled cohort calculator. Came out with 5.9%. What would you do next? Do you want to start him on statins, either high or moderate intensity? Do you want to start him on low dose aspirin? Or do you want to do an ultrasound of his abdomen to screen for an abdominal aortic aneurysm? Or you just want to send him home with lifestyle advice and then follow him up? Now, this is the moment where you hit pause and think about the answer. Meanwhile, I'll talk about how you would approach this question. Now, before we think about the options, I want you to really understand what this question is trying to ask. So, this question is trying to test whether or not you know all the risk factors for atherosclerotic CVD and how you want to intervene to decrease his risk. Mainly, the big question is whether or not this patient should have statins or not. So, let me ask you, what do you think is the most important risk factor for CVD? And if you answered a previous history of CVD, you would be absolutely right. Now, what all does that include? That includes any history of MI, any history of angina, whether stable or unstable, any history of peripheral vascular disease, or stroke. Now, our patient does not have that, but let's take a look at what all other risk factors he has. Here. So his age, his sex, and his ethnicity can be risk factors. But the big one here is really his history of diabetes. He also has a past family history of CVD, so that's one. But how about his labs? What do you feel about his lipid profile? Now let's take a look at, let's compare it with the normal and see what you think about it. So what do you think? Do you think this patient should be started on a statin based on his lipid levels? Do you remember what are the cutoffs for doing so? Well, in case you were thinking, let me just tell you that was a bit of a trick question, as there are no absolute lipid levels above which you would start a statin. Now, if you remember this graph from the multiple risk factor intervention study, this shows that your risk for CAD increases linearly with your plasma cholesterol level, and there is no absolute cutoff value in which the risk drastically changes and that you would, benefit from starting a statin. So what is the purpose of doing a lipid profile? Well, we do it to calculate the overall risk for CVD in a patient using one of these calculators. Now, let's take a look at what that calculator actually talks about here. Now, this is the calculator that we use. This is the AHA, also called the pooled cohort equation. Now, this sees takes into account your age, your gender, your race, as well as your total and HDL cholesterol levels, your blood pressure, and whether or not you're a diabetic and a smoker to calculate your CVD risk. What patients can we use this calculator on? Now, again, the first thing you have to see is that we can only use it for people who have not had a previous atherosclerotic CVD, like our patient. Then it can only be used for 40 to 79 years of age. And also you have to make sure that the person's cholesterol level is less than 190. Why so? because anybody with an LDL more than 190 is likely to have some sort of familial dyslipidemia, and you would automatically start a statin for this patient, so there's no point in really calculating a 10-year risk. Now, the next thing we're going to do is, let's go back to the whiteboard and see what are the populations that need statins based on their 10-year risk of CVD. Now, as we talked about, the population at the most risk for CVD is people who've had a previous episode. Number one, they should definitely be started on a statin. Now, apart from this, there are 3 other populations which would need to be started on statins. Now, the next population is people who are diabetic and more than 40 years of age. They need to be on statins too. And third population is based on your risk for, again, CVD, more than 5%. Now, this is according to the AHA guidelines. There are a number of other guidelines which differ slightly on it, and we will talk about them later. But for the purpose of the exam, you would be safe to remember, go by the AHA guidelines. And the fourth population, like we talked about, is anybody with an LDL more than 190 who probably have some sort of familial dyslipidemia. Okay, now the next question that we have is about the intensity of statin therapy. Do you want to start the patient on low dose, moderate, or high intensity statins? Now, you might be tempted to just start the patient on a particular intensity and then titrate it according to a target LDL level. Now, let me show you the evidence on that. Well, there's absolutely no evidence that doing so is going to benefit the patient or improve outcomes, and it might actually harm the patient by leading to over or under treatment. So instead of this, what you're going to target your therapy is based on the change or the percentage decrease in LDL levels from baseline, based on what intensity you start him on. So now let's look at what the guidelines are for deciding what intensity to use in each of our populations. Now, the first group is, again, people you're using statins for secondary prevention. That is, people who've actually had CVD before, and they should be started on a high intensity statins unless they have any safety concerns or if they're older than 75 years of age. Now, the next group, like our patient, people who are diabetic and more than 40 years of age, we're giving them statins for primary prevention of CVD. And the decision to use a high or low intensity statin depends on their 10-year risk of CVD, and if they have a risk of more than 7.5%, you would start them on high intensity statins, and if it's less than that, like in our patient, they can be started on a moderate dose of statins. And the third population, again, is non-diabetics with calculated risk of CVD more than 5%. Again, if it's 5 to 7.5%, you would give moderate intensity, and anything more than 7.5% gets moderate to high intensity statin. Now, this is where things get a little bit contentious, like I mentioned earlier. And for that, let me just pull out this really interesting paper on the major dyslipidemia guidelines in the US and their discrepancies. Now, like I said, for the purpose of the exam, you just need to know the AHA guidelines, the ones we just talked about right now, and you'll be able to answer most of your questions using them. But just to cover all bases, let me touch upon another important US guideline and how it differs from the AHA. Like we just said, the AHA recommends starting statins for anybody with a risk more than 7.5%. However, the US Preventive Services Task Force differs in it that it recommends starting statins for risk more than 10%, and it also suggests a different intensity of statin for this age group. Now let's go back to our whiteboard. I think this is all you need to know about using statins for the USMLE. Now let's take a quick look at the other options. Now, what do you think about starting aspirin? When do you do that? Now, you would start aspirin in patients aged low dose aspirin in patients aged 50 to 59 years of age with a CVD risk more than 10%. This is according to the US Preventive Services Task Force. But before you do that, you have to make sure that they are not at increased risk for bleeding. Now, looking at our fourth option, when would you do an ultrasound of the abdomen for screening for an AAA? Well, you would do this in people who have ever smoked and are of ages 65 to 75 years, and you would just do a one-time screen. And males, you do it only in males, and it's not recommended for females. This is again according to the US Preventive Services Task Force. And how about our last option? Well, although you would always suggest lifestyle modifications to this patient, but as we talked about, he definitely needs a statin in addition to that. Now, what all lifestyle modifications are we talking about? This patient definitely needs to be on a diabetic diet. How about exercise? Is he getting appropriate exercise? Well, not really. The current recommendations are of around 150 minutes per week of moderate to vigorous intensity exercise. That comes around for around 30 minutes for 5 days a week. Our patient is getting way less exercise. Plus, as he is diabetic, you would tell him to not to sit still for more than 30 minutes and interrupt with some light form of exercise. Okay, now let me take you back to the high point of this question, the table we discussed about statin, in case you need to review it, right? With this, we have covered most of the important guidelines and recommendations regarding cardiovascular health, which are important for the USMLE. I hope you found the videos useful, and do let me know if you have any questions or comments regarding this, or if you have any topics or vignettes that you would like me to discuss. I've added the links for whatever resources I used, I referenced for preparing these videos in the description below, and feel free to check them out. And again, thanks for watching, and all the best for your prep.